Weight loss. Case. Dear Doctor. Sarah Jones, aged 24 years. This young woman has noticed that her clothes are becoming looser fitting, despite her eating normally, and she is sure that she has lost at least 5 kilograms in weight, even though she is not on a special diet and has a generally healthy lifestyle. On closer questioning, she has also noticed some diarrhea recently and feels tired most of the time. I would be most grateful for your assessment. Yours sincerely. Introduction. Tiredness is a common and non-specific symptom. Weight is usually fairly constant and loss of 5% or more of the usual body weight must be taken seriously. Although malignancy is an obvious concern, particularly in older patients, in a young woman the diagnoses of malabsorption, thyrotoxicosis, diabetes mellitus, and intentional weight loss are more likely. Table 6. NB. Diabetes and thyrotoxicosis are very common. Diabetes affects 1–2% of the population and thyrotoxicosis affects 1–2% of women at some time in their lives. History of the presenting problem. Weight loss. It is vitally important to actually document this, on the same scales if at all possible. Patient perceptions are sometimes misleading and to embark on a protracted series of investigations for a problem that does not exist is clearly not sensible. If patients have not weighed themselves, ask if clothes or trousers have become looser. Rapid weight loss, particularly in middle-aged or elderly patients, is often associated with malignancy. Ask patients directly if they are trying to lose weight, how does their weight now compare with that 5 and 10 years ago? Have they been on a diet recently, or at any other time? NB. Make sure that the patient has actually lost weight before embarking on a hunt for a cause of weight loss. Appetite. Decreased appetite invariably leads to weight loss and is a feature of many diseases. Weight loss in the context of a good or increased appetite is suggestive of thyrotoxicosis or diabetes mellitus. Diarrhea and steatorrhea. The latter is a sign of malabsorption and is characterized by loose, oily, bulky, offensive stools that are difficult to flush away. It can be caused by mucosal disease, e.g. celiac disease, Crohn's disease, or by pancreatic insufficiency, e.g. chronic pancreatitis, cystic fibrosis. Remember, however, that diarrhea does not necessarily imply a primarily gastrointestinal cause of weight loss, it may be a feature of thyrotoxicosis. Abdominal pain should alert to the possibility of Crohn's disease, particularly if located in the right iliac fossa and associated with weight loss. Repeated attacks of central or epigastric pain, especially in the context of high alcohol intake, should raise the possibility of chronic pancreatitis. Pain does not occur in celiac disease. Other relevant history. In this young woman it will clearly be very important to inquire if she has had problems with anorexia nervosa or bulimia in the past, also about features that suggest diabetes mellitus, polyuria, polydipsia, or thyrotoxicosis, tremor, agitation, etc. Family history may be relevant. There is a 10% risk of celiac disease in the offspring of an affected parent, and diabetes and thyroid disease also have a genetic component. Unlikely in this woman, but much commoner in an older patient, would be a past history of malignancy. If there is, then onset of weight loss is very suspicious of recurrence or metastatic disease. Plan for investigation and management. A wide range of conditions can cause tiredness and weight loss, but often the cause is evident after the history and examination such that only a few investigations are necessary. In the absence of an obvious clinical diagnosis, the following would be appropriate. Urine and blood tests. Check urine with dipsticks for glucose, blood, and protein. Check FBC, electrolytes, renal, liver, bone function tests, inflammatory markers, erythrocyte sedimentation rate and/or C-reactive protein, glucose, thyroid function tests, malabsorption markers, ferritin, folate, B12, and anti-tissue transglutaminase antibodies. Celiac disease often presents insidiously. Consider short synacthin test. NB. A raised platelet count may be found with chronic gastrointestinal blood loss, but it is also an inflammatory marker that is often raised in active inflammatory bowel disease, especially Crohn's disease. Imaging. CXR, look for tuberculosis, mediastinal lymphadenopathy, or, very unlikely in this woman, but common in older smokers, bronchial neoplasm or metastatic disease. Abdominal ultrasound or, better, CT scanning are non-invasive and may detect inflammatory masses or thickened edema. 2 loops of small bowel in Crohn's disease, intra-abdominal collections, lymphadenopathy, or renal carcinoma. Other tests. Other investigations may be directed by clinical suspicion or preliminary test results, e.g. lymph node biopsy, but if there are no clear clinical diagnostic leads and nothing has emerged from the blood tests described, CXR and abdominal imaging, then further investigation is almost certainly not warranted, and it is likely that attention can most fruitfully be directed towards psychological causes of tiredness and weight loss, e.g. eating disorder or depression. If iron deficiency anemia is present, both the upper and lower gastrointestinal tract should be investigated. Barium follow-through or small bowel enema may reveal Crohn's disease. Celiac disease is confirmed by total or subtotal villus atrophy on duodenal biopsies, Fig. 7. NB. Do not forget that the radiological appearances of intestinal tuberculosis may look identical to Crohn's disease, so keep a high index of suspicion, particularly in Asian patients. Management. Management will be dictated by the specific diagnosis made.